Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Talha Badr from Mayo Clinic Cancer Center, Florida, and he's going to lecture us on upfront immunotherapy in acute lymphoblastic leukemia. This webinar is brought to you by Pfizer, Unipath, Netco, Lucian, and Nirvid Life Sciences. And this webinar, as usual, is brought to you by Mumbai Myology Group, supported by Perfect Square. And I thank Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Myology Group. Our guest speaker for the day, Dr. Talha Badr from Florida. All our discussions were themselves very eminent hematologists as well as medical oncologists. And you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, we have got 3 lectures. At 10 a.m. onwards, we have mantle cell lymphoma, navigating through biological heterogeneity and management in 2025 by Dr. Gopinathan M. from Chennai. Followed by that, at 11:30 a.m. onwards, we have Lieutenant Colonel Dr. Ranjit Pethu Varghese from Pune, speaking to us on non-fragmented approach to fragmentation hemolysis, case-based approach. And followed by this, at 1 p.m. Indian Standard Time onwards, we have Dr. Ramesh Balasubramanian from Madurai, speaking to us on glofitamab regimen improves survival in large B-cell lymphoma. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. So these are very eminent hematologists, hemato-oncologists all over the country. So these are our discussions for the day. Now it's time to introduce our guest speaker for the day. We have no other than Dr. Talha Badr from Mayo Clinic Cancer Center, Florida. Let me introduce Dr. Talha Badr to all of you. He has come over this platform multiple times, but it's again my formal duty to introduce Dr. Talha Badr to all of you. Dr. Talha Badr is a physician scientist with the Division of Hematology and Oncology and an assistant professor at the Mayo Clinic with special interest in high-risk acute leukemia and myeloid disorders. He is leading the consortium on myeloid malignancies and neoplastic disease, that is COMMAND, where they are conducting retrospective and prospective studies. He has conducted several studies evaluating outcome of TP53 mutated acute myeloid leukemia, which is one of the high-risk leukemia and with great unmet need. Through his work, he was able to highlight genomic landscape in Hematologica 2024, racial disparities in Cancer 2023, and impact of novel therapies and bone marrow transplantation on outcome of TP53 mutated AML in American Journal of Hematology 2022 as well as Leukemia 2023. Observing very poor outcome of patients with high-risk myeloid neoplasms spurred his interest on to develop innovative clinical trials for affected patients. He did observational and correlative studies evaluating clinical outcomes of myeloid neoplasms associated with DDX41 mutated germline predisposition syndrome. He also observed lack of typical MN-associated somatic mutations and age-related chronic hematopoiesis in DDX41 mutated MN in ASH 2023, suggesting need for better understanding of mechanism of disease progression in DDX41 mutated myeloproliferative neoplasms. He is currently conducting single-cell sequencing and functional studies to better understand leukomegenesis in DDX41 mutated GPS with the hope to detect therapeutic vulnerabilities that could lead to clinical trial opportunities. Recently, he has started working on clinical trial concepts in collaboration with NCI Experimental Therapeutics Clinical Trial Network, that is ETCTN, focusing on myeloid disease with high unmet needs. Today, he's again with us and he's going to lecture us on upfront immunotherapy in acute lymphoblastic leukemia. Well, thank you so much. I stop over here. Over to you, Dr. Talha Badr.
Hi, thank you so much, Dr. Khurana, for a nice introduction. And it's a pleasure to be here again on this forum and have hopefully an interactive discussion on the updates and management of acute lymphoblastic leukemia and what's new in the field. And I'm sure most of us joining this webinar will be aware of the utility of upfront immunotherapy and significance of this immunotherapy improving outcomes. So I will share my screen. Can you all see this
Yes,
transition? Okay.
perfect.
Yeah. So as I mentioned, and you can hear me as well clearly.
Yes, perfect, sir. Please go ahead.
Okay. So we'll be discussing today on upfront management immunotherapy in ALL. Actually, I'm in another conference, so I sneak out for some time to have this discussion on ALL. Uh, so these are my disclosures. So the objectives of today's discussion is to highlight the significance of immunotherapy, predominantly in B-cell ALL, because that's the place where we have seen an evolution of treatment algorithm, not so in T-cell ALL, where we're still struggling to find better way than conventional chemotherapy and transplant to prove outcome for that high risk and aggressive subgroup of leukemia. So we'll divide the discussion of upfront therapy based on pH negative B cell ALL and then pH positive B cell ALL, and would like to also highlight the concept of chemo free regimen in B cell ALL with the evolution of very potent and effective therapies which are tolerable. Now the field is moving from a chemo free approaches based on the success we had with immunotherapy in B cell ALL. So, as I've been highlighting, this figure gives a idea or a glimpse how we have done over the last 2 decades or so in the management of not only pH negative but also pH positive ALL, and mainly due to introduction of immunotherapy based approaches, where we've seen initially for relapsed refractory and MRD positive disease, but now with upfront therapy, we are reaching a improve long-term outcome up to 85% in AYA adult patients and also close to 60 to 70% in elderly ALL patients. Similarly, if you look at the pH positive B cell ALL, with introduction of potent TKI, starting with imatinib, then dasatinib, then ponatinib, we have really seen significant improvement and drastic changes in outcome of that group of patients with long-term survival up to 80% with introduction of blinatumomab upfront immunotherapy with potent TKI such as dasatinib or ponatinib. So why the field is moving to utilize upfront immunotherapy? Although with chemotherapy approaches, especially in younger or AYA, when I say AYA, adult young adolescents group, with the age group from 18 to 39, with the introduction of asparaginase-based chemotherapy backbone, we have seen a high CR rates, but those CR rates, especially for patients with high-risk molecular aberrations, are not long-lasting. And when it comes to elderly patients who are 60 plus or 60 years of older, their response or tolerance to multi-agent chemotherapy is not good. Compared to AML induction, the mortality from upfront conventional chemotherapy-based approaches in elderly ALL is up to 10 to 20% because of poor tolerance to high-dose steroid and chemotherapy-based induction for that subgroup of patients. And also, in elderly patients, there also a inherent resistance to conventional chemotherapy-based approaches. As we have seen in your practice, we see more complex chromosomal aberration in the elderly patients. And we are noticing more and more therapy-related ALL also in that subgroup of patients because these patients have prior cancers or evolution of disease or clonal metapoiesis that happens to concurrently occur in this subgroup of patients as they advance in age. So this is the first case presentation before I jump into sharing with you the data. 57-year-old male with medical history for hypertension, impaired glucose tolerance, sleep apnea, and hyperlipidemia, who presented with abdominal pain, thrombocytopenia, and leukopenia, as you can see here. Initially, due to predominantly severe thrombocytopenia, this patient was managed with ITP. However, due to inability to improve the count, patient was referred to a tertiary care center at Mayo Clinic, and bone marrow biopsy was consistent with B-cell ALL, pH negative, as you can see by the flow cytometry. So the first immunotherapy introduced in the management of ALL was rituximab. Rituximab is a anti-CD20 monoclonal antibody, and initial reports suggest why we come to rituximab, because rituximab was initially evaluated in B-cell lymphomas, but we also noticed that CD20 expression, which occurs in 1/3 of the patient with ALL, seems to have an adverse prognostic impact on outcomes of this disease. So phase 2 study of small group of patients, like 31, was conducted in combination with hyper-CVAD chemotherapy. It did show a response rate of 86% with improvement in EFS and overall survival. And the outcomes were better from historical cohort of patients who were treated with hyper-CVAD chemotherapy alone. Hyper-CVAD is a combination of 6 drugs in which you give hyperfractionated cyclophosphamide, vincristine, daunorubicin, and dexamethasone, alternating with high-dose cytarabine and methotrexate. So with this positive phase 2 study results, a phase 3 study was conducted by Graal group, a German group, where rituximab versus no rituximab with intensive chemotherapy was evaluated in randomized fashion. As you can see here, impressive CR rate. The thing to note, the rituximab arm, the event-free survival and overall survival were more favorable than those patients who didn't receive rituximab, received chemotherapy alone. So rituximab did improve outcome in combination with intensive chemotherapy, but the issue with long-term rituximab-based combination, it can lead to B-cell aplasia, and especially in older ALL patients, you tend to see more complication, infectious complication down the road when they persist on therapy for a longer time. So the UK NCRI trial was conducted in which they minimized to 4 doses of rituximab during induction. The initial trial, which I've mentioned to you, they've utilized the CD20 expression cutoff of more than 20% or more by flow cytometry. In this trial, they utilized 4 doses of rituximab in combination with chemotherapy in patients 25 to 65 years of age, regardless of their CD20 expression. However, the event-free survival or overall survival, including patients with CD20 expression, wasn't significantly changed in the outcome based on CD20 expression. Furthermore, the long-term outcome was inferior among patients with advanced age and the presence of high-risk chromosomal aberrations, including those with KMT2A gene rearrangement. So in summary, for rituximab, a single-arm study in combination with intensive chemotherapy, regardless of CD20 expression, didn't show to improve long-term outcomes significantly as an inferior among patients who are older or have high-risk chromosomal aberration. So prior to the blinatumomab and inotuzumab era, the rituximab combination incorporation was welcomed because we have some immunotherapy-based approach that is shown to improve outcome in randomized fashion. However, as I mentioned earlier, CD20 is not expressed in all B-cell ALL, it is expressed in 30% of patients. Moreover, in older patients, the randomized study which I've cited utilized 16 dose rituximab, and it may be well tolerated. It may not. It doesn't. It's not well tolerated in older patients, and so we need a better immunotherapy-based approaches. However, we still use CD20 positive, the rituximab in CD20 positive ALL patients. However, there was a need for therapies which can be given readily in all ALL patients, not only in 20-30% of patients who express CD20 20% or more. So this brought in the discussion on blinatumomab. Blinatumomab is a bispecific T-cell engager anti-CD19 monoclonal antibody. and it was initially approved for relapsed refractory B-cell ALL patient based on the Tower study published by Dr. Kantarjan et al. In NEJM. Later on, it was also approved by FDA for MRD positive B-cell ALL post-induction, and most recently, it has been approved as a consolidation therapy among B-cell ALL patients who are MRD negative, which has shown. Well, I'll discuss that paper with you, which led to the approval of this drug in later slides. But just to give you a brief introduction on the blinatumomab. So we know that rituximab, blinatumomab was approved for relapsed refractory MRD positive ALL. Since our today presentation is for upfront immunotherapy, so I'll be discussing more blinatumomab utilization with upfront chemotherapy or non-chemotherapy based treatment approaches for management of B-cell ALL. So this first study was conducted at MD Anderson by Dr. Jabbour and colleagues who limit the hyper-CVAD up to 4 cycles. Traditionally, hyper-CVAD is given up to 8 cycles, part A, part B, alternating with cyclophosphamide, vincristine, daunorubicin, dexamethasone with high-dose cytarabine methotrexate. This hyper-CVAD chemotherapy we have seen in our clinical practice, and you all must have seen also, older patients who are 60 and above, or maybe 55 and above, the tolerance of hyper-CVAD chemotherapy is not great, with recurrent admission with neutropenic fever, treatment delays, and dose modification requirements. So they would limit the hyper-CVAD to 4 cycles, followed by 4 cycles of blinatumomab. And during maintenance, which is usually 2 to 3 years in ALL, the blina was interspersed 3 monthly up to 1 year. It was a small study of 38 patients, but the CR rate around 81%. More importantly, the MRD negativity was achieved in 76% of patients. It was a single-arm study, but it did show that blinatumomab was reasonably well tolerated with improvement in long-term survival. Similarly, the Jemima group, the Italian group, utilized blinatumomab with A-by-A chemotherapy regimen. What are A-by-A chemotherapy regimens? A-by-A chemotherapy regimens are derived from pediatric regimen, where we've seen the best success rate in improving outcome of ALL. Basically, these regimens are more rich with pegasparginase-based combination and high-dose steroids, as well as intensification consolidation chemotherapy with strong chemotherapy-based approaches. So they intersperse blina with A-by-A chemotherapy regimen up to 2 cycles. And the primary endpoint of this trial was to achieve MRD negativity. And as you can see here, among the 149 patients enrolled, the complete remission rate was around 88%. 70% achieved MRD negativity, which translated into improvement in disease-free survival and overall survival. The primary endpoint was met with the MRD negativity, which after blinatumomab improved significantly. And patients who had PH-like phenotype, their benefit outcome, we know that PH-like is a subgroup of B-cell ALL patient that tends to have an inferior outcome, and their response to immunotherapy-based approaches are relatively inferior to those who doesn't have this high-risk phenotype. So there randomized studies are ongoing, which are incorporating inotuzumab with A-by-A regimen 10403 in A-by-A patients. This comes to the trial that led to approval of blinatumomab as a consolidation therapy among MRD negative B-cell ALL patients. It was a randomized phase 3 study done over the span of 10 years from 2013 to 2023, in which there are 2 groups of patients, one who received chemotherapy alone, and other, as you can see here from this treatment schema, who received blinatumomab as a consolidation strategy with the chemotherapy backbone as up to 4 cycles. Patients who are younger than 55 years of age received pegasparginase, and patients with CD20 positive expression were allowed to receive rituximab, and transplant was pursued among high risk transplant eligible patients. So as you can see here, significantly the Kaplan-Meier curve showing the blina chemo arm significantly improved survival compared to chemotherapy alone arm. And with the median follow-up close to 4 years, overall survival was not reached in the immunotherapy arm. And 22 patients in each received transplant. So the proportion of patients receiving transplant were compared between two groups. 80% of patients received more than 2 cycles of blinatumomab. That was predictive of improving outcome. This is the forest plot. As I mentioned earlier, peach-like phenotype is that subgroup patient who doesn't respond well to blinatumomab, as we have seen in earlier Germany group study also. So we have talked about immunotherapy in combination with chemotherapy. Now I will share a couple of trials in which blinatumomab was utilized without chemotherapy. The first one from the SWOG group, where Dr. Advani and colleagues evaluated the steroid blena combination followed by pump maintenance among older B-cell ALL patients. And the idea behind utilizing this, as I mentioned earlier, the older subgroup of patient A, they have inherent resistance to chemotherapy. B, their tolerance to conventional chemotherapy with high dose steroids is suboptimal. So we're utilizing a chemo-light or chemo-free approaches to treat this group of patients. Although the idea was unique and very innovative, but it didn't translate into improved disease-free survival or overall survival, which I've seen in earlier studies I've mentioned to you in AYA younger group, where we have seen the overall survival close to 80%. The overall survival is around 37%. Having said that, this subgroup patient, as I mentioned earlier, were more enriched with high-risk chromosomal aberrations that lead to inferior outcome. So that will come again to blinatumomab chemo-free or chemo-light approaches on later slide. Now we'll move our discussion to inotuzumab with chemotherapy. So blinatumomab strategy with upfront chemotherapy is not utilized. The reason behind that is blinatumomab is not a good cytoreductive agent, so utilizing blinatumomab upfront may not achieve the desired goal, whereas inotuzumab can be given as an upfront therapy which has better cytoreductive action. As I mentioned earlier, with blina steroid-based induction in older individual, we haven't seen improved outcome, and these patients have a high induction rate mortality, as I mentioned earlier. So there's always a need of newer strategies, which are chemo-light in combination with novel drug in management of B-cell ALL. And we know ENO did show significantly improved outcome compared to conventional chemotherapy in relapsed refractory setting that led to this approval of this drug in ALL. So inotuzumab is a antibody drug conjugate, targets CD22 and delivers a cytotoxic drug called calcamicin. As always, MD Anderson has been a pioneer in making innovative treatment strategies for management of B-cell ALL. So this was also initially conducted at MD Anderson, where they utilized upfront ENO with mini CVD. What is mini CVD? Mini CVD is that it's without anthracycline and lower dose of cyclophosphamide, lower dose of dexamethasone. With hyper-CVAD, we give 40 milligram dexamethasone from day 1 to day 4 and day 11 to 14 in this 20 milligram per meter square from day 1 to day 4 and day 11 to day 14 in hyper-CVAD A arm. And the B arm has also reduced methotrexate and cytarabine. So it's a mini CVD in combination with ENO in older individuals who may not tolerate the more intensive chemotherapy regimen. ENO was given on day 3 for first 4 cycle. And as you can see here, that the response rate was significantly better, 85%. Remember, with Blina steroid combination, the response rate were close, but the long-term survival was not as good as you can see here in this 3-year survival, close to 50% or so. However, long-term follow-up did raise the concern that patients were dying in CR due to complications related to chemotherapy and inotuzumab. So this is the Alliance study, which I was referring to earlier, in which inotuzumab in a randomized fashion incorporated with intensive chemotherapy regimen. So that was conducted to see if incorporating inotuzumab will improve outcome. So unfortunately, that study didn't pan out as intended, and the outcome of inotuzumab in combination with intensive chemotherapy regimen didn't improve survival. The main reason behind is this because high proportion of patients died in the inotuzumab arm. So the study was put on hold by FDA and now being revised, in which the inotuzumab dose has been reduced and blinatumomab is being incorporated to improve outcome. So we have talked about blina chemotherapy upfront. We have talked about chemotherapy upfront. Now, this slide where upfront was used with sequential blinatumomab, right? So this study, the was kept at 2.7 milligram in total because of the issues with liver toxicity and VOD. And after 4 cycles of mini-CVD Plena was given up for 4 cycles. However, the idea was to improve outcome, but sequential Plena in this single arm study didn't show to improve outcome compared to mini-CVD alone. Another study in which was utilized with age-adapted chemotherapy, similar to the earlier study by Alliance, which I've showed, and done by GMAL group, a German group. And 43 patients were enrolled in this study, 100% CR rate and 70% MRD, which is consistent. The MRD, a deeper response have been seen with upfront immunotherapy, chemotherapy-based approaches. And these results were encouraging. The smart thing they did in this study, they had an age-adapted chemotherapy for younger patients, received more intense chemotherapy backbone versus older, less intensive chemotherapy backbone. So we have discussed 3 trials in which inotuzumab was given in combination with chemotherapy. Now we'll share results from a trial where was given without chemotherapy, and that is the chemo-free treatment for elderly PH-negative ALL 60 years and older from Alliance Group by Medvedev and colleagues. And in this study, they've utilized upfront inotuzumab for 2 cycles. If these patients achieve adequate disease control or reduction, were given blinatumomab as a consolidation strategy. And the primary endpoint was to improve 1-year event-free survival. So, as you can see here, from Plena, if you recall the SWOG study which I mentioned to you, where utilizing steroid Plena and pump maintenance, the long-term survival was around 30%. In this study, by a shorter follow-up, you can see the event-free survival around 75%. So it significantly improved outcome when was given sequentially with Blena rather than Blena followed by maintenance chemotherapy. And to my understanding, this paper is under review, and soon the details and granularity of this analysis will be available for all of us to read. So in summary, is efficacious therapy for B-cell ALL. Unlike Blena, it has a better cytoreductive potential and a better treatment strategy upfront. In sequential use of Blena, although single-arm study did show to improve long-term outcome. So second case I will discuss is a 74-year-old with history of multiple myeloma, had an autologous transplant, later on workup of cytopenia and B symptom found to have ALL, and performance status was not as great. So how would you treat? So the answer is there on the presentation which I've given you earlier. We'll go and the conclusion I will share how I treated this individual. Now moving a couple of slides for pH positive ALL. So far we've been discussing pH negative ALL. So pH positive ALL, the outcomes are more better than pH negative ALL, thanks to the potent TKI based approaches, which has tremendously improved outcome for this group of patients. I just want to stress on the fact that it's not the chemotherapy that has improved outcome, it's the potent TKI based combination, a good effective target, as you can see in this, which have improved outcome with long term survival up to 5 years across the age group. This is the DLPA study in which the dasatinib was utilized with steroids as an induction, followed by blinatumomab. As you can see here, deeper response were achieved in long-term survival, as I mentioned earlier. It's a very good long-term outcome. Although utilizing dasatinib in ALL, there's always a fear that disease evolution with resistant mutations such as T315I, which was seen in this study on a longer follow-up. So that led to the question, if you're fearing about emergence of resistance mutation and such as T315I, why not utilize ponatinib with blinatumomab? And this study done for that particular reason, as you can see here, you would rarely see a Kaplan-Meier curve in ALL showing that straight line, although the follow-up was short, around 1.5 or 2 years, but significantly improved outcome on utilizing this approach. However, when we utilize a chemo-free regimen, there is a more incidence of CNS relapses because you're not giving cytarabine methotrexate, which crosses the blood-brain barrier, right? So you rely on intrathecal chemotherapy. And the school of thought is that when you're utilizing chemo light or chemo-free approaches, you might have to go up on the number of intrathecal chemotherapy you give for CNS prophylaxis, and some people recommending up to 15 cycle. However, clinically, what I've seen here, patients are reluctant to receive that much intrathecal chemotherapy. I usually stop at 12 cycle and later on give a couple of intrathecal chemotherapy when they recover from the toxicity of chemotherapy and IT chemotherapies. So the case number one, which I showed earlier, we treat on E9010 protocol and doing well MRD negative by clone-seq NGS-based PCR. The case two, elderly with therapeutic ALL, prior myeloma history, induction for blena, and he's really doing well with the MRD negativity achieved after blinatumomab. So although the immunotherapy have improved outcome for B-cell ALL patients, challenges remain. CD20, if we talk about rituximab, is not expressed in all ALL cell, and prolonged use of rituximab leads to more infectious complication. Inotuzumab, we always fear about liver toxicity, especially among patients whom we are considering bone marrow transplant, and we should limit inotuzumab to 2 cycle to minimize the risk of VOD or sinusoidal obstruction. Blinatumomab is a great drug, but it's not have a good cytoreductive potential, so it should be given with chemotherapy backbone if utilizing upfront. And certain high-risk genomic profiles, such as pH-like disease, blinatumomab may not be ideal and need to combine with other more novel therapies, as we have discussed. So with this, I would like to thank you all for listening to this presentation.
Thank you, Dr. Talabadar. Wonderful talk as always. Fantastic. And I now request all our discussants to please put the hand raise signs so that we can start our question answer session with Dr. Talabadar. Yes, we are first with Dr. Mehat Rehan. Your question, please.
Am I audible, sir?
Yes, you're audible. Please go ahead.
Sir, thank you, sir, for a very clear and comprehensive talk. Sir, I would like to know in this era of immunotherapy, which subsets of patient do you still consider for allogenic BMT in CR1?
Yeah, that's a good question, Max. So definitely patients with a high-risk genomic profile, hypodiploidy or p53 mutation, or those with pH-like disease, patients who unable to achieve deeper molecular response by ideally by clone-seq and with PCR after induction consolidation, These are the group of patients, and therapy-related ALL. We see more and more since our myeloma patients are living longer, and we did report that this is also on the horizon, therapy-related ALL, as we see in AML. So all this group of patients, if are donor available and they're eligible, should proceed with transplant.
So one more question, sir. Sir, you have talked extensively about B cell ALL. Sir, what about T cell ALL? Where do you see the role of nelarabine?
Yeah, the T cell ALL is an orphan subtype, right? For T cell ALL, we rely on chemotherapy. If these patients are younger, we get like pegaspargines with chemotherapy and try to take these patients to transplant. Nelarabine is a good option, and it has shown to improve outcome in a salvage setting. But as we have seen, the nelarabine tolerance is not great. I see more and more CNS toxicity. Patients are unable to tolerate. In combination with chemotherapy, is more toxic. So nelarabine is a good choice since we don't have much, but still a lot of need to be done to improve outcome for that group of patients. So people are trying to incorporate daratumumab. Daratumumab is a CD38 monoclonal antibody, and so it's readily expressed in T cell ALL. And daratumumab has been utilized with venetoclax, a BCL2 inhibitor. And I'm also leading this ECOG ACRIN cooperative group study in which we're utilizing daratumumab for MRD positive disease in T cell ALL to see if we can achieve a deeper response and bridge these patients with transplant. So for now, if you answer is short, immunotherapy hasn't panned out for this group of patients. We rely on chemotherapy and transplant to improve their outcome. There are few studies evaluating novel CAR T cell therapy targeting CD7, as well as daratumumab venetoclax based combination. So these are the strategies. Subgroup of these patients may have a KMT2A gene rearrangement. So people are utilizing menin inhibitors in combination with chemotherapy.
Thank you, sir.
Thank you, Dr. Mehak Rehan. So from the same note, I have a question for you. Those patients which are Icarus plus versus Icarus only, do Icarus only will require transplant as compared to Icarus plus? Icarus plus is definitely transplant, but only
Yeah,
Icarus.
that's a very good question. The Icarus one only hasn't shown to be independently predictive of outcome. So Icarus Plus, right, definitely. But I would base my decision for Icarus one based on depth of response to make a call about transplant. If they are MRD negative after induction consolidation, that you might consider. Otherwise, we'll continue with chemotherapy, immunotherapy based approach.
Thank you, sir. Dr. Dinesh Burani, sir, your question, please.
I'm just asking, we have four things: chemotherapy, blinatumab, inotuzumab, and CAR-T. Younger age and elderly. Is there any trial which way we are going? How much chemotherapy to be added to this? Whether the CAR-T will be utilized to reduce the. Is there a trial where we can look for the right combination with the minimum toxicity and maximum output?
Yeah, that's a very good question. So we're still in the works. There a lot needs to be done. Although we know the upfront immunotherapy-based approach improve outcome, there's certain subgroup of patients who still doesn't do that well. So the way the field is moving, we are trying to utilize, as I've mentioned earlier, incorporating ENO with with chemotherapy to control disease, followed by sequential Blenard. The other approach is utilizing CAR-T for MRD positive disease after utilizing upfront immunotherapy, chemotherapy-based approach. In older patients, the Alliance trial, which I've mentioned, utilizing ENO for Bablina, did improve outcome. We are moving forward. The cutoff for that study was age 16 older. Now we are utilizing up the current series of trial ongoing, utilizing this chemo-free approach is 55 and older, and they're looking for incorporate BCL2 inhibitor to improve outcome for certain subgroup patients with high risk phenotype. So, and we don't know how many blinatumomab cycles are enough when utilizing with chemotherapy. The E1910 ECOG study showed that patients received 2 or more. were able to achieve desired response. So maybe 2-cycle blinatumomab incorporating inotuzumab sequentially or BCL2 inhibitor, utilizing CAR-T for MRD positive disease after induction consolidation, especially among individuals who may not a right fit for transplant or may not have eligible donor. Uh, for chemo-free approaches, more intrathecal prophylaxis, up to 15, as I mentioned earlier, maybe incorporating a couple of cycles of cytarabine methotrexate combination to give that CNS protection and so forth. And although dasatinib, plena, dasatinib-based combination are good, but there's emergence of T315I mutation. So there are studies in which ponatinib being utilized in cooperation with chemotherapy and immunotherapy to prevent those occurrence of resistance mutation.
Thank you.
Thank you, sir. Dr. JP Meena?
Yeah, Dr. Talla, very nice presentation. So myself, Dr. Jagdish Meena from AIMS Delhi. So I want to ask, what is your experience of using upfront rituximab in BALL? First question. Second, what is your take on reducing doses of conventional chemotherapy while using rituximab altogether? We have seen patients when we use rituximab with chemotherapy, there is a lot of immunosuppression happens. Patient land up in a severe neutropenia. So I have these two questions.
Yeah, that's a very good question, Dr. Meena. So first, we know from pre-rituximab, pre-immunotherapy era, the CD20 expression was predictive of inferior outcome. CD20 is expressed in 30% of ALL, B-cell ALL. Initial studies suggest that when you combine rituximab with chemotherapy, you improve event-free survival and overall survival. However, the German study, the NGM paper, which shows to improve outcome, gave 16 cycles of rituximab, and that lead to significant toxicity, infectious complications, as we have pointed out. Later on, the UK NCRI study, keeping that in mind, that more rituximab leads to more combination, utilized only 4 cycle rituximab, but that didn't pan out to improve outcome. So although we are utilizing rituximab in combination with chemotherapy, but in older individual, it may not be feasible to give that long stretch rituximab. Ideally, we should utilize blinatumomab as available or inotuzumab to improve outcome for that subgroup of patient rather than relying on rituximab alone at this day and age. When we didn't have those therapies, might have an option, but especially in older individuals, even in younger individuals, prolonged use of rituximab is not advisable. You limit them up to 4 to 6 cycles and utilize other immunotherapy-based approach.
Right.
Yeah, thank you.
Thank you, Dr. Meena. So there is one question from the audience. Dr. Karthik wants to know that in the era of immunotherapy, where do you place the transplant in B cell precursor ALL, which are pH positive as well as pH negative?
Yeah, that's a good question. So I did mention the pH negative ALL still transplant has a role in high-risk genomic profiles such as those with pH-like disease, hypodiploidy, P53, those who doesn't achieve AMRD negative disease after induction consolidation by more sensitive techniques such as clone-seq, NGS-based PCR, those patients still should be considered for transplant. For pH positive disease in the era of more potent TKI, if you have a younger individual, transplant still have a role in improving relapse-free survival, if not overall survival. There's no prospective study, but there's several retrospective studies, including our group as well as another MD Anderson and other colleagues have shown that patients who achieve complete molecular response, BSAR ABL less than or equal to 0.01 at 3 months from the time of induction consolidation, the benefit of transplant improving survival was not there. However, relapse-free survival is improved. So if a younger individual with pH positive disease, even though you achieve a deeper response, still transplant can improve their relapse-free survival, if not overall survival. Overall survival not improve because we have better effective therapy than salvage setting, so the picture get milkier. But an older individual, let's say 55, 60 years old, if you achieve a deeper response, I won't take these patients to transplant. I think chemoimmunotherapy-based approaches followed by maintenance TKI is good enough to achieve a longer disease control. But in younger individuals, I still feel transplant has a role. It's an ongoing discussion, and you discuss with your patient and see how convinced they are with the data and what they want to do. Because transplant, even US, wherever you do, there is 20% 1 year mortality. Either you do reduced intensity, which you often do for ALL, or a myeloablative conditioning. So it's an ongoing discussion. Some of my younger patients in 30s, 40s, they see the data and they don't want to pursue transplant, and they are doing well 3 years down the road with ponatinib maintenance therapy. However, we need to make sure long-term ponatinib, even in young individuals, can lead to cardiovascular complication. So better management in terms of utilizing, monitoring their lipid profile and high blood pressure and so forth, utilizing ACE inhibitor or statin if they are on long-term ponatinib with the maintenance therapy to minimize the risk of those cardiovascular events.
Thank you, sir. Another question he has is, uh, what would be better for extramedullary disease, INO or VINA?
For extramedullary disease, I don't know if any study have shown that, but we know that ENO is better cytoreductive therapy. But these patients should be consolidated bone marrow transplant. They're in high risk group of patients. So we utilize sequentially both treatment, but I don't know if any study have shown Blina is better than ENO, but ENO definitely has a better cytoreductive potential.
Thank you, sir. Sir, I have a question for you. In a financial restrained settings like India, where the patients are not affording for INO, VINA, those who are CD20 positive, good expression, pre-BALL. Most of them, we are using immunotherapy protocols. During induction, we are using with prednisolone, vincristine, L-aspergillase, and so on. Putting rituximab in this scenario, in induction, how many doses are required? Because you said 16 doses we are not able to give. 4 doses not valuable at all. So is it really justified taking rituximab anywhere in induction to just go for a good RFS benefit and some OS benefit anyhow by just 4 to 6 doses with BFF protocols?
That's a very good question, very relevant. I would try to give 1 to 2 cycle of enoblina rather than doing rituximab for that group of patient. If the cost effectiveness, we cannot give 4 cycle of eno, 4 cycle of blina, or 5 cycle of blina, but if we can do a couple of cycle of either one of the agent, I think that is a better approach than utilizing rituximab for 6 month cycle in with chemotherapy backbone, giving toxicity and financial toxicity and toxicity on the health. So I don't see greater role rituximab. And it's better, we are better off in doing transplant if possible.
Anybody has any other question apart from this? So there are no more questions in the chat box now. Well, sir, thank you so much. Wonderful talk, as always. Good to hear from you. Thanks a lot, sir. Thank you.
Thank you so much. My pleasure to be with you all. Thank you. Have a good weekend, all guys.
I thank all my discussants as well as audience to join here today. Thank you so much, sir, once again.